All right, so this is the 8th discussion session for health and homelessness. Today we'll be talking about drug abuse, substance abuse, and harm reduction ideas. But first I want to talk about a few things. A few weeks ago we did have the one-night count. So the one-night count is put on by the Seattle-King County Coalition on Homelessness. And 2 teams from this class actually participated in the count. One team had a bit lower count, and another team actually found 9 people sleeping outside on that cold January evening. So the count this year was actually kind of depressing in that there was a 14% increase in the number of homeless people, men, women, and children on the street that day. So 3,100 people compared with 2,700 the year before, and then even the year before that there were less than 2,600. So we've seen about 500 more people found on the streets, and there could be other factors contributing to that, but the guidelines they use to carry out the count are pretty standard across the different number of years. Thanks everyone for attending Dental Action Day. If you're a dental student, I think we had a large presence. You can see that was an image actually from that day. But advocating for homeless populations doesn't end at Dental Action Day. Maybe it can begin then. And so if you have an interest in advocacy, join an advocacy group or become involved in ASDA or other organizations, whether it be for your profession or for homeless populations or other marginalized populations. I think we had a big impact, and legislators like to hear from students. And so I've got the outreach opportunities that you can participate in online, but I wanted to talk about 2 different things. So the Common Book Series and the Public Health Dentistry Journal Club. So the Common Book actually this year is on a topic similar to what we'll be hearing about today. Dr. Gabor Mate from the downtown east side of Vancouver wrote this book, and he's actually coming in a few weeks to talk to the school. There's a lunchtime informal session, there's a screening, I think, with film, and then they'll be giving a keynote that evening from 7 to 9 in Kane. And all that information is on the course website, and I'll send that out as it gets closer. But the book is, I can just read this here, that this insightful book explores the scientific and psychological causes of addiction, as well as the impact on the addicts treated at the downtown Eastside Vancouver Clinic. Is a physician. So it's really relevant to this class and relevant to today's topic, so I recommend everyone read that book or go to the session. The second thing I wanted to talk about was the Public Health Dentistry Journal Club. So a couple students started the local chapter for the association, and they started a journal club that closely ties into the topics that we discussed here with homeless populations. The next discussions, or the next session for the journal club is next week for that, and we'll be talking about policy development, which kind of ties in with Nancy Almaday's talk 2 weeks ago. So before I give it up to our speaker today, don't forget to sign in and complete the speaker evaluations. So a little bit about Caleb. Caleb Banta-Green, a research scientist with the Alcohol and Drug Abuse Institute and an affiliate assistant professor with the University of Washington School of Public Health, has been featured in a Seattle Times article about heroin use spiking in young adults. Dr. Banta-Green holds a BA in biology from the University of California and has received a Master's of Social Work, a Master's of Public Health and Community Health, and a PhD in Public Health and Community Health from the University of Washington. He has a number of research interests, including youth abuse, prescription drugs, drug treatment outcomes, and health services research. Without further ado, let me introduce Dr. Caleb Banta-Green.
Thank you. So I'm very jealous that you guys have comfortable seats. You still have bruises in the seats. So I'm an epidemiologist, I'm a health services researcher, and I'm increasingly doing more drug policy research and such. Let me just hold this thing. And I'm just going to take a little more than a half hour and just share some information with you, but I really want to hear what you guys are thinking about and what's interesting and important to you in the midst of all this. I can talk about a lot of different stuff. What I have prepared is a little bit around going over what are the general drug trends going on in King County. I want to talk specifically around some sort of novel, newer things around overdose prevention, maybe not quite, but close to the epitome of harm reduction, and talk about it in that context. And just mention a couple projects that I'm working on now or have been working on recently. A big piece in all this work I like to say is, I work very close with the medical examiner and working sort of backwards from overdose deaths and trying to find sort of root causes, what's going on. And I like to say I got a little bit tired of counting all the dead people and started doing more intervention research a few years ago. I have an intervention study, a 5-year randomized controlled trial in UW-MC and Harvard U, the emergency departments doing overdose prevention. And what we're doing with folks is we're aiming for, optimistically, 500 heroin users and 500 prescription opiate users. And essentially what we're doing, the intervention with them, is to do brief overdose education, show them how to assemble and use take-home naloxone intranasally, have them talk about an overdose risk reduction plan that might work for them, since they're not going to give themselves naloxone during an overdose, and help them sort of write up that plan. And then we're following up with medical records data actually going out up to 10 years, and follow phone interviews. So that's my first intervention trial. So I chose an easy population and an easy setting to do that work. But I'll tell you, one of the first challenges I ran into was my eligibility criteria. One of them was, well, I want to be able to follow people up for my 3 follow-up phone interviews. I better get some really great contact information for people. And if they can't give me 3 other contacts, they're not in a study, which was really awesome, except that I had no homeless people in my study after a month. So I changed that criteria, and now we have 60% homeless, which is good. Challenging, but good. So, and that 60% number is actually interesting. I do a lot of work with public health, Seattle King County, around a syringe exchange survey, the last 3 administrations in 2013, 2011, and 2009, and I was just looking at the numbers on my way up those stairs, and about 55% of those injection drug users are homeless. And actually, stunningly to me, I have a medical student working with me, and I'm just having to do a stratified analysis just by age and gender, because there's this really young emerging group. We just cut things at age 30 and younger, and over 30. And there's no difference in homelessness among people by age, which I don't know why that surprises me, but it surprises me. It's about 50-55% among both of those groups. And actually more incarceration among young adults, about 45% have been incarcerated in the last year. So this isn't just, homelessness isn't just about people getting older and worn out, right? It's also about people getting wrapped up in addiction and having serious mental health issues early on, and a lot of that really emerging in adolescence. So I will stop with that intro. And come on, this is a Macintosh. I don't know how to use this thing.
Use the pointer.
Oh, what? You just push the button. So I'm going to talk a little bit about some data. And yes, I did do a lot of epidemiological training here, but if you can't understand it with me just doing my arm like that, then there's not going to be any statistical significance test here. So I'm just going to talk about police evidence. I talk about data from leading to lagging indicators. Drug use measures are difficult, right? Hidden problem, hard to count. So we use police evidence about what's on the street. It's a good supply indicator. We look at treatment data, mortality data, a little bit on infectious disease, and I'll talk about syringe exchange. And then I'll come into some stuff around overdose. And I can go quickly here. This is kind of ugly. What do I want to tell you? Oh, does this thing work? Which button?
The arrows at the top, you see right and left? Oh, the pointer is in the middle.
Oh, see, there I did it. I'm just going to talk. So that's fine. So let's just look at the right side. It doesn't matter. The left side's numbers, the right side is percentages. There's some interesting things going on in Washington State. And these data are really kind of wonky to look at. I'm going to go over here. Okay, good. So this top line red is cocaine, and that's that number absolutely tanking. That's both a supply indicator, and it's also about a Supreme Court ruling that changed some issues around evidence. So some weird data in there. We still have plenty of cocaine, although it's certainly declined. That's sort of an urban focus in Washington State. So that's cocaine. And you can think of a lot of reasons, even though cocaine is maybe not the major drug getting used, about why it shows up in law enforcement data in terms of where emphasis is, which populations are dealing drugs in open market versus indoors and such. So there's a lot behind that data point. And let me see what else. I haven't looked at this slide. Okay, so I'm having a hard time seeing this. Is this a little out of focus? Am I hallucinating? You can tell me I'm hallucinating. It's okay. Sorry, it's marginal. So talk a little bit about cannabis. Huge spike in cannabis. There started to be a lot of emphasis as people were talking about loosening up regs, and then it just loosened it up, right? It just tanked in terms of what we're seeing with marijuana. I'm going to talk a little bit about the opiates in particular. Prescription opiates really increased and then dropped off, and you can see heroin increasing dramatically. And the heroin, I'll show you more, is really across the state, and that's what stands out. These are the same data, just looking at heroin and prescription type opiates. I focus on those because, one, I vaguely understand them, having worked in a methadone clinic, having worked with chronic pain patients doing research at Harvard Group Health Cooperative, and also because we actually have an antidote. We actually have something people can do, and we have medication-assisted treatment, so that's sort of my domain. And what's interesting is, the last time I ran these data was through 2009. So in 2009, I was like, whoa, heroin's up, prescription opiates are up. And then prescription opiates started to decline, and heroin, these numbers are actually preliminary, they've continued to go up. So we're seeing, just continuing things going on at the population level. These are the same data in map format. This is prescription opiates about more than a decade ago, where they were in a state and where they were a couple of years ago. Heroin, where it was a decade ago and where it is now. So basically went from nowhere to almost everywhere. You went from sort of major metropolitans and good old Aberdeen to really pushing out to a lot more places, not everywhere. Drug treatment emissions. You do not get the caveats. So this is looking at King County versus Washington State, and just walking across this. This is 1999 through 2012, publicly funded. Huge underestimate of the actual number of people because it's none of the private pay, insurance paid folks. Okay. So basically, looking at here, you'll see cocaine is down in King County. It's down across the state. Heroin, where's my heroin? Heroin is up a little bit here in King County. You can see that bump up, but statewide, you can see just a really dramatic increase in heroin among people of all ages. Methamphetamine declining across much of the state. Marijuana, slight declines, and then prescription opiates are really peaked in a couple years ago, and they're coming down a little bit. Okay, this is 18 and 29-year-olds, and they're kind of the canary in the gold mine, right? Particularly just to remind people that addiction is a chronic relapsing condition. Opiate addiction in particular can have sort of permanent neurobiological changes, and people are grappling with addiction potentially for their whole life. So heroin increased in King County among this population 224%. Statewide, it increased 500%. In this age group, heroin surpasses alcohol for why people are coming into treatment. Okay, this is a change. This is a dramatic, fairly sudden change in terms of what's going on with addiction, and it's really predicated on pharmaceutical opiates and abuse of those drugs, sort of priming the pump. People who had a predisposition to opiates 20 years ago, 30 years ago, they didn't really have an access point. Now there's so much opiates being prescribed and or diverted and shared that many people who are predisposed are now being exposed and becoming addicted. I think it's really important just to note on that there is a real difference in whether people are using opiates as prescribed to them in a carefully controlled way, and sort of the idea of iatrogenic addiction is really something we don't see a lot with opiates unless a person has a prior history of addiction. That's really where we see things go off the rails. I got too many mics. So first-time admissions to treatment for people reporting heroin, this is incidence. That other number was treatment admissions. It's heavily duplicated. It's really a prevalence measure. It's a health services measure. This is really an incidence measure. And I should be really clear, this includes almost none of buprenorphine. People heard of buprenorphine or Suboxone? Basically, very briefly, if you think about opiate addiction, the long-standing medication, methadone, is a medication-assisted treatment, essentially replacing one opiate with another with a stable dose of opiates, and methadone has long been that med. Buprenorphine is another med. It's a partial agonist, partial antagonist, has a ceiling effect, it's potentially safer, can be prescribed out of prescriber's office, so there's potentially greater access there. However, there's not a lot of public funding for that modality, the Suboxone. So again, these data are going to be a dramatic undercount. I'd say by about 50% in terms of what we're seeing in the state. Is this mic just too long? Yeah, that's better. So this is looking at heroin treatment admissions. First time coming into treatment in Washington State. You get all sorts of. She's in. I'm getting a cold, so I don't really want to go. So what we're looking at back here, in 2003, about 600 people came into the public system for the first time for heroin, and a minority, about a quarter of them, were 18 to 29. Now we're up to 1,400, and the majority, almost 2/3, are 18 to 29. So this is just incidence. I just told you, opiate addiction doesn't magically disappear ever, let alone after some treatment. So these are folks who are going to be dealing with addiction in some manner for the rest of their lives. Let's see, route of administration. Just very briefly here, let people know what's going on. This is King County, people coming into treatment. You know, most of the cocaine among low-income folks who are coming into treatment is smoked still. Most of the heroin is injected. Prescription opiates is still mostly oral. We get some smoking and some injection. Marijuana is smoked for the most part. And methamphetamine is largely smoked, although we have had for quite a while an injection issue with methamphetamine in this area. And then just looking at very different age distributions. This is looking at 1 year, just 2012. How old are people when they are coming in? And this is from youngest group to older group. So cocaine, really talking about kind of an aging cohort of users, okay? That's cocaine. Heroin, this looks very different than it did a decade ago. With this 18 to 25-year-old group, late 20s. So you've got this group here, 40% are under the age of 30. Prescription opiates, also you see that sort of trend towards a younger group. Marijuana, largely, a lot of that's under 18. And then methamphetamines is actually fairly well spread out across the age spectrum. So this is my spaghetti plot. These are drug-caused deaths. This is the number of times drugs are identified. About 2/3, 3/4 of the time, there are multiple drugs on board. It's the minority of cases where there's a single drug-caused deaths. So the y-axis here is not the number of deaths, it's the number of times drugs are identified. Okay? So I'll start here, which is heroin. Back in '97, we had a lot of heroin, and we had a lot of heroin mortality. We had much higher purity there. It was still crap. It was still 15 or 20%, but it was higher purity than our 3 to 5% pure. So that's part of the reason, even though we have more heroin use now, that we had more deaths back then. Purity was higher. There was a lot of mixing with alcohol. That came down for quite a long time, and then it's really increased steadily, and actually increases into 2013. This is the pharmaceutical opiates. Really started declining. 2008 is when prescribing started leveling off for oxycodone, methadone, and morphine in Washington State. Mostly in reaction to probably the state's guidelines around opiate prescribing and some of those rules, and then eventually those were codified in law. Yeah?
That's what I was going to ask, if there was an effect of that, and then the tamper-proof.
Yeah, so let me mention a couple things around prescription opiates. So the agency medical director is really driven by Dr. Franklin at LNI. Definitely changed sort of the medical climate in terms of prescribing for opiates. And that really started in 2008 or so. In 2010, in the fall, OxyContin was reformulated, the extended release form, obviously it's OxyContin, from a crushable form to essentially, you try to crush it, it doesn't turn into powder, it turns into a gel-up mess. And I actually think that's one of the biggest impacts we've seen in terms of pharmaceuticals. And then we did have a prescription monitoring program start in October, well, technically January 2012, and there's no way we would have seen that effect yet in terms of the prescription monitoring program. I mentioned very briefly, the prescription monitoring program in Washington State are now in effect in almost every state in the United States. It is a single database of all controlled substance prescriptions. It's essentially a pharmacy database where pharmacists have to enter every controlled substance dispensing, I shouldn't say prescription, dispensing at the time of dispensing. And then clinicians have an option of checking it at the time of prescribing. It's C2 through 5, so it's all those classes. Obviously you get your sleep meds, your muscle relaxants, your benzos, and your opiates. And the issue is in Washington State, as in most states, is that a minority of physicians or prescribers, I should say, are registered with the system, and many don't even look at the system when they make prescribing choices. So I actually am working with the Department of Health to analyze the complete data set that I just got last week, and totally off the record, in 2012, there were about 2.2 million people in Washington State who got a controlled substance prescription. That's like a third of the state. And over the 2-year period, it was almost half the state. I find that a stunning number. I mean, you know, some of that's that one prescription for Vicodin with the ankle sprain. But, you know, some of it's a lot of other stuff going on. Okay, drug-caused deaths, my favorite topic. So prescription opiates coming down, prescription sedative, benzos mostly. 99% of deaths with benzos involve other drugs. It's the hamburger helper of drugs, is what my colleagues actually say. It's not good, unlikely to kill you by itself, but the combination is very dangerous. Alcohol has actually been a tricky thing to measure over time. I'm not going to belabor that. Methamphetamine actually just recently spiked up, and there's no obvious thing driving that. We really saw methamphetamine peaks and trends back in 2005. It came down a little bit, and it's been sort of steadily increasing. But this isn't just an aging cohort. This is not just older folks. This is actually distributed across the age span. I'll stop there. So just overall, though, whether it's heroin or prescription opiates, about 3/4 of all deaths involve an opiate of some type. And the point is that obviously any overdose death can be prevented, but most of these could be reversed before they become fatal. The majority of opiate overdoses take a couple of hours for death to actually occur, and the majority of times other people are actually present. So a big deal, and I'll talk about it later, is actually recognizing an overdose. It is one of the biggest things we just want to teach people. By age, I'll just note overall that this big increase in this older group over 50 was prescription opiates. These other categories sort of held on, and this increase more recently here is driven by heroin. And I'm going to not go through all this. And so, I know this is a data table. I'm supposed to talk about the data. So HIV, the main point about HIV is we have really low HIV incidence. Our primary exposure category is women who have sex with men, and that's largely because, Tacoma in 1988 started the syringe exchange. We've had a very robust syringe exchange program dating back to the late 80s. Hepatitis rates are much, much higher, obviously, than we see with HIV. But if you look at this in terms of these categories here, let's see here. So MSM are 77% by risk category, straight up IDU, no pun intended, 5%, MSM IDU, another 9%. So this sort of dual category of IDU is about 14%. That's quite different than you might see in a place like New York City, where you can see a larger proportion of injection drug users. Yeah?
Could you define what the percentage was again of that? Was it?
It's the exposure category for people diagnosed in that period.
Okay.
Yeah, sorry. And this is just to show Hep C infection across the state. Depending which numbers you look at for injection drug users, somewhere between 40 to 70% are infected with hepatitis C. Those are very large numbers. And this chart, you'll notice, looks a little bit like that heroin chart. The strong southwest piece, and you've actually got a strong Whatcom County piece. As you know, with Hep C, it's a real delay until diagnosis. So we don't really have good incidence data for hepatitis C. And I'll mention as a quick sort of political note, one of the things that's going on in Washington State, and it actually came out of federal guidance around HIV dollars, those HIV prevention dollars are following HIV incidence. HIV incidence in Washington State is men who have sex with men who are in Puget Sound. And you just saw the maps I showed you about where all the new young heroin users are, which is everywhere else. So we have this thing where policy is basically saying, hey, you're doing really great suppressing that thing. We're gonna move towards high incidence, not recognizing what's going to go on in terms of HIV risk. And we specifically know that a paper I did a couple of years ago with a colleague, that younger group, that prescription and heroin group, I should say, 60% of those under the age of 30 report that they began using prescription opiates before they began using heroin. That they were hooked on prescription opiates before heroin. So that is the pathway. And that younger group has way lower HIV risk perceptions and HIV testing rates. Okay, so syringe exchange. So this is the volume of syringes, and this is the number of encounters. So we're up to almost 6 million syringes just in King County in 1 year. Just in King County in 1 year. Just think about that. That's a lot. And we have syringe exchanges in Snohomish, and we have them in Pierce County. So this isn't like it's all secondary exchange into those places. It's a lot of syringe exchange. And a lot of that, I will tell you, People's Harm Reduction Alliance, which if you ever walk up in the alley by a Lego or behind the post office, is the card out there where people are doing syringe exchange. That's this red. And from a harm reduction perspective, I'll share with you what they've done is they've gone from a one-to-one exchange model to a distribution model. If I come in and I don't have any syringes with me and I say I need 1,000 syringes, they're going to give me 1,000 syringes. So that's a pretty dramatic change. And it goes in counter to sort of the economic idea of, well, syringes have value if I can exchange them. But they were finding that that was a barrier to people actually getting syringes, and there was too much reuse of syringes, so they went to a straight-up distribution model. There's some argument, there's some sort of public debate about that in Olympia, where there's a lot more young heroin users on the street. Actually, I was just in a meeting last week with all the police chiefs in Snohomish County, where there are young homeless heroin users all over the street in Arlington, right? So something huge is happening here. So in terms of these trends real quickly, heroin's up, it's spreading geographically and among young adults, so there's big geographic and demographic shifts. Prescription opiates are down somewhat. I'm going to ignore the stuff about fentanyl because it's really complicated. So the point is, overdose education and naloxone work is still in a building phase. This law was signed by the governor 4 years ago around Good Samaritan and allowing distribution of take-home naloxone more readily, and still trying to build both supply and demand simultaneously, which is like my side gig is doing that. Cocaine is down a bit, meth is increasing again. Marijuana appears generally level. It's hard to know in a saturated market what's really going to happen with legalization. We'll find out. Yeah?
This might be an ignorant question, but is naloxone readily available?
It's not ignorant, it's a segue, and I thank you for it. Wait 1 minute, I'll tell you about it. There's a lot of synthetic crap out there too, so the other big thing I didn't touch on at all, frankly, it's a measurement mess. Are all the synthetics, cathinones, which relate to the cot plant coming out of East Africa, cannabinoids, are actually cannabinoletics, they're not actually related to cannabis, but they bind to the receptors. They're out there, and they sort of ebb and flow a lot. They're legal, they're illegal, and you can only really detect them by chemical measurement. I haven't talked at all about Molly or ecstasy or methadone or any of that. There's a lot more sort of synthetic stuff coming out of, mostly out of China. And I do a whole other bit of my work is working with young adults around those substances and trying to get people to figure out what are they actually using, and what are the impacts of those substances. So that's a whole other piece. And I am hearing from infectious disease docs everywhere that Hep C is increasing among young injectors, but it's not sort of registering in the data yet. So that's it for sort of big scale drug trends. I'm going to pause for a second and see if there's any questions about drug trends before I take up that gentleman's segue. Anyone? Yeah,
I
please.
was wondering if the decrease in opioid use because of various things, tampering with paper and education of providers and so forth, is there less access to opioids, and so then people are going to heroin because they can't get opioid?
So the question is about if there's less access to pharmaceutical opioids, do people go to heroin? I don't think a person who's popping Percocet and can't get the Percocet is going to jump over to heroin, right? So I really think it's people who are abusing those meds. And just to explain, people probably know this, this sort of typical pharmaceutical opiate escalation is, I'm taking a few pills, I happen to be the person that likes them, I use them a little more often, I use them during the week when there's a reason to celebrate, I use them during the week when there's a reason to be sad, I start using them more often, I start getting tolerant, my dose starts escalating, and I started finding out that actually I keep trying to get that euphoric high that I can't get anymore, and you find out, well, the stomach's not a very effective way to seek that. The nose is a pretty good way to do that. So you start snorting, and then eventually move on to injecting. And at that point, you're paying $80 a pill. You could get $10 worth of heroin. You're doing the exact same thing. I wish you guys, if you're really bored right now, look at you guys are not looking on the laptops. Thank you. If you were looking at an oxycodone molecule and a diacetylmorphine or heroin molecule, and you squinted, you wouldn't be able to tell the difference. They're the same thing. They're engineered to be the same thing. That's on purpose. So it's a perfect biological substitute. So then you have economic issues and availability come in. That make sense? All right. Okay, opiate overdoses. So overdoses can be prevented. Probably guess how. So most opiate, heroin prescription opiate overdoses can be intervened upon before death ensues. Really low overdose knowledge, the risk factors, what are the signs of an overdose, how to intervene, and really making sure you're giving that education to anybody who is interacting with in the life of somebody who's a regular opiate user. I don't care if you're a chronic pain patient or you're a pill abuser or a heroin user, everybody in your life, I would hope, would be aware of the signs of an overdose and know something about how to intervene. I'll give you a quick example. So I sit on child death review, and the family situation was basically a mom who had a chronic health condition, had been on opiates for 10 years. an adolescent child in a household, and a couple of other adults. And one morning, the other folks in the household who were not opiate users noticed this teenager snoring in this really kind of weird way. And it's kind of late in the morning, but they're like, she's a teenager, they write her off. And of course, they find her dead a couple hours later. And so I can think of 5 lessons there. 1, the med should have been locked up. 2, the conversation should have started 10 or 8 years earlier about why those meds might be safe for the mom and not for the kid, right? Starting having that conversation on medication safety really early on. You need to recognize the classic warning signs of an overdose. You should have naloxone in the house, and you should know about the Good Samaritan law, and so the patient won't be charged for any sort of possession type things in that situation. Pretty straightforward when I say it that way, but in the reality of the situation, none of that was happening. So, not in that situation, but in a lot of other situations with people of criminal background, maybe because of their drug use or warrants, there's a lot of fear of police in terms of calling 911 during an overdose. And I did a lot of research, which I won't go into today, around that, interviewing police, interviewing paramedics, interviewing heroin users. And everybody agrees the actual arrest of an overdose is phenomenally rare. All of them agreed around that. So we actually worked on getting the police involved and doing public education around that so that those perceptions could change, because the perceptions was driving a lot of that behavior. So an antidote is available, and I'm going to talk a little bit about this. The supply and access points are limited, and there's a lot of work right now to try to expand that. So in terms of this overdose knowledge, ways to increase that. So just general awareness, I like to say, opioid overdoses can be prevented, and they can be reversed before they become fatal. And what I hope is people will say, oh really, please tell me how. So this is a national problem. I'm showing you Washington State data. We're actually a little bit on the leading end. As we saw the prescription opiates getting reined in a little bit earlier than the rest of the country, we're seeing the emergence of heroin a little bit earlier than everybody else. But it is a national problem. The dynamics are exactly the same across the country. So I already said regular users should have overdose education and take-home naloxone. Let me just pause on that for a minute. Oftentimes people get sort of stuck on naloxone. Like, oh, you're giving a person an antidote, isn't that a crutch, isn't that an excuse, yada, yada, yada. I actually think more important than naloxone is the overdose education. If you don't know how to recognize an overdose, none of the rest of it matters. If you don't know that an overdose is about oxygen deprivation, you're not going to understand what to do. So you need to know how to respond. You need to know when and why to call 911. You need to know to do a sternal rub to actually see if the person is going to wake up. You need to do rescue breathing. You need to understand why chest compressions may not be relevant. Ignore everything you learned in the CPR class, right? It's about oxygen deprivation. It's about rescue breathing. If you have naloxone, giving it and continue giving rescue breathing. And understand naloxone lasts at most 90 minutes, and depending what they're taking, that naloxone is going to wear off pretty quickly. So they need to be, ideally, have medical aid, and if not, at minimum, have somebody staying with them for many, many hours afterwards. Okay? That was my 1-minute overdose education. So I think everybody in their community really needs to know about that. For me, something I actually was part of the group that met 3.5 years ago, and it took 3 years for it to come out of the federal DHHS, the Substance Abuse and Mental Health Services Administration, put out an overdose prevention toolkit. What's exciting is when I first went to the meeting, they wanted to build this toolkit for people in methadone. And now when it finally came out, it's actually geared at everybody. Anybody who's at risk for overdose and their family should get overdose education and consider prescribing naloxone to them. So I want to mention this website, which I put up the website as soon as the law took effect, initially just to educate people about the law. And there was no take-home naloxone out there, so I didn't really have anything on naloxone. I got a small grant from the State Attorney General that wrapped up in the summer to basically build up this website, did a lot of work with community groups, sort of building up the content and language. And I'm meeting in 2 hours with my MPH student to go over about 600 surveys we've got online. From online training, about 450 people have done the training online. I trained about 200 people in person, and then I got to do one video conference training with folks over in Spokane. And we're just going to look at, via these different modes, what is the overdose, so we have a knowledge quiz, a confidence in the ability to respond, and sort of plan behaviors around actually sharing that information and getting take-home naloxone. So this website, right now it's actually very much geared around opiates because that's what I was working on. I'm getting a lot of interest in expanding it and being a little more generic around a whole range of substances. whether it's Molly or whether it's alcohol. So this is gonna get revamped and prettified, but it's something I've worked very hard on. This, you basically land on the page, it's overdose education. I've done trainings with folks where I just use the website purposely to show them that they have the same information. Watching either of these videos are the same content, different messengers. Left side is a nice New York heroin user geared video, and the right side is a nice North Carolinian pain doctor talking to a nice pain patient. Same content, different messengers. And then just a little review, and we go a little knowledge quiz and such. And then we talk about where to get naloxone, sources for a whole different type, bits of help, what law enforcement can do, including law enforcement can potentially decide to actually carry tape on naloxone. If they're in rural areas with a long delayed ALS response, that's something that some police departments are considering, some of the tribal police that way. Some of the research we've been doing, a lot around pharmacy and prescribing practice. I'll come back to that in a minute, some of the other drugs and some of the new stuff. But yes?
I was just going to ask, from a health provider standpoint, what is our kind of boundary of liability and responsibility when we are prescribing or giving out something like naloxone? I think there's an assumption that overdose is a possibility, so use or kind of non-directed or undirected use is a possibility. So where does that sort of fall in our line of responsibility?
We should probably spend the rest of the time on that. So there's a couple of different things. I'll review a few things. So there's state law that covers now prescribing naloxone to a person at risk for having or witnessing an overdose. From that perspective, from the state, you're covered. There's several medical journals, and I may or may not show you those articles, that now are giving medical guidance that this is a recommended practice. The State Department of Health last week, when they put out the mortality data for 2012 that showed prescription opiates going down and heroin going up, recommended that prescribers check out the stopoverdose.org page on prescribing practices, right? So it's becoming normalized. Now, in working with clinicians, I get a lot of different responses. Well, shouldn't we just get them off their opiates? Shouldn't we just get them down on their opiates? And you can have that as your goal, but a risk-benefit calculus is going to be made for some people that you're going to continue them on opiates. And in that instance where there's opiates in the home, that presents a hazard to your patient and to everybody else out in their home. And that's the other thing we haven't talked about is everybody else in that home is also potentially at risk. And so it's talking not just about naloxone, but about overdose education, talking about combining with benzos. I'm actually in the process right now with the State Department of Health of trying to make that prescription monitoring program not just a place that you dump in data, but that actually is a clinical decision support tool. That'll kick back and say, well, you've got a person in front of you who's had 3 prescribers in the last month, and they're on 300 milligrams morphine equivalent, and they're on benzos. That person is at elevated risk for overdose. I encourage you to review the prescription monitoring program for that person and consider doing overdose education. And if you think this is appropriate medical care, do that overdose education and prescribe take-home naloxone. That's where I hope we are a year from now. We're not there yet, but we're trying to get there. So there's actually some of those tools are built in. So I probably touched on part of your question, but what else was in there? Anything else?
I think that's actually most of what I wanted to know.
Okay.
Thank
Yeah, I
you.
mean, I can't say you are immune from ever anything bad happening to you.
Right.
I wish I could say that.
And really, it's just, the question is coming from more of a point of professional responsibility and healthcare provider responsibility and wanting to do the right thing by your patient,
Right.
when knowing that I think there's this inherent and obvious knowledge of a problem there when you're providing something like naloxone.
Right. Well, and I mean, it's all about embracing the gray. I mean, I'm doing a lot of work with Kelly Ross Pharmacy, and so a model I just want to mention to you is actually a pharmacy distribution model. So I worked with them for probably half a year to get it up and going, and then I went in and I said, I'm at risk for witnessing an overdose. I'd like some naloxone. And they said, oh, nice to see you again, Dr. Banta-Green. Come on over here to our patient education room. They did education with me, and then I went up to the counter and paid for 2 doses of take-home naloxone. I only saw a pharmacist. You know, that is a huge access issue right there, and a nice model for a lot of the rest of the state. It's also a nice access point. I love hanging out in the alleys of the U District. I'm from the neighborhood. I've been doing it my whole life. Not everybody loves to hang out in the alleys there. Some of them would rather go to the polyclinic pharmacy at 7th and Madison, right? So having different access points, I think, is pretty important. Is there another question or comment? Okay. So there's that. What is naloxone? I'm going to assume you know what it is. I'm just going to mention it is a full-on antagonist. It is preferentially binds to opiate receptors. It binds to them but does not activate them. It is a prescription medicine. It is not controlled. It's extremely safe. It is not abusable or addictive. And of course, it's been used for several decades in all sorts of emergency situations. The only contraindication is a theoretical risk that has never once been documented. So naloxone access, who can be prescribed? In Washington State, as I mentioned, anybody at risk for having or witnessing an opiate overdose. Given that 1 in 5 adults is prescribed an opiate every year and 1 in 10 adolescents, it's a large proportion of the population. Also given that nobody ever throws their meds away or uses all of them. So, where can you get it? So we have a locator there, but slowly, increasingly having some physicians prescribing it. The syringe exchanges are starting to carry it. Public Health, Allegheny County, their syringe exchange carries it. So it's getting to be out there more and more, but it's slow. In Rhode Island, I believe, all the Walgreens pharmacies just started stocking it. So medical providers could prescribe that to people at risk for having an overdose. A lot of different care settings. I'm not going to go through them all. There's a good argument for primary care, emergency departments, pharmacy, drug treatment, and also jail. We're actually hoping, we're like about to start in the Kent jail doing overdose trainings and then putting naloxone in people's possessions when they leave. That is the highest risk period for an overdose for a heroin user, is that time leaving jail. Or similarly, anytime tolerance is interrupted, right? Insurance could cover, Medicaid does pay for naloxone, intranasal and intramuscular, and increasingly private insurers are. I mentioned pharmacists could prescribe and dispense. This is actually via something called a collaborative practice agreement. It's signed off on by a doc with an established protocol that allows that prescriber to directly dispense the med. And in theory, there's something called screening, brief intervention, referral to treatment, which is a billable code, often in emergency departments. The idea is that almost universal screening in emergency departments for addiction is a good thing, given that up to half of people are in ERs because of substance use. So why not do universal screening? Similarly, a brief intervention would be overdose education. So it's not turned on, but it's something that could be paid for by Medicaid and other payers. And then, of course, I'm hanging out with my pharmacist friends. They think they should be paid for their time. So that might be a nice thing. So real quick, when police show up, we do this Good Samaritan law. I have an overdose and you're with me. You call 911. We both get immunity from drug possession charges. Very importantly, I did do survey work with the police. 16% had heard of the law, only 8% had an actual factual understanding of the law. So I went back to them. Oh, and 2/3 have been in an opiate overdose in the prior year. 2/3 of Seattle police have been in an opiate overdose in the prior year. So this very fine gentleman, who wasn't a narcotics captain at the time, kicked off this training video, which starts with him saying, here's this law, these police officers are going to follow it. The prosecutor comes on and explains what the law does and does not cover, and then the medical director for public health comes on and says, here's what naloxone is, and here's what the research shows are the impacts of distributing table naloxone. This is that overdose toolkit, which I'll just let people know about, and this is my amazing Facebook page. So I'm actually getting a lot of communication out there. As I mentioned, we did advertising for 1 month in June on Facebook in King and Spokane counties, and got a ton of sort of uptake. It was fascinating to the social marketing people I worked through. This was the highest click-through rate I'd ever seen for anything, this topic of overdose, so which I was surprised by. So it actually is quite the amount of interest out there. And I think I'm going to stop there. There's a lot, basically everything's on stopoverdose.org, or if you're interested in the trend stuff, on adai.washington.edu is my workplace with all my reports and such. So any sort of questions or comments, and I'll stick around, please.
Yeah, I was wondering, now that, the education about hospital, right? When people start thinking, there's an antidote or food, overdose. So when that just lead into thinking, okay, I can just keep taking drugs. And
Yes.
When we see an increase in
That's a great question. Let me see if I have it up here. That is the, do I have it up here? Well, that's the safety net argument, right? I got a safety net I'm going to use more. What I like to say is that naloxone is not a very comfortable parachute. It puts you in a sudden acute withdrawal. Right? So if you're opiate tolerant, you're going to feel terrible. So people who've had naloxone don't want it again. So that's the basic argument there, and it's what we find with some of the preliminary research out there is that if you distribute naloxone, on average, most people don't take more risks. Do some people? Yeah, some people do, but the vast majority do not. What I do not say to people who are opiate users is it's kind of like a parachute with barbed wire straps. It'll stop you. It's not going to feel real good. You don't want to keep jumping out of that airplane in that way. So it's an important thing to be mindful of and to talk through with folks, but in fact, it really does not lead to increased use. Yeah?
Can people generally recognize an overdose in themselves, or does it have to be someone else who sees it and intervenes for them?
Essentially, it's got to be somebody else, right? Because if you're using opiates and you're trying to get high, you're going to nod. You're going to be nodding. So, I mean, you really need to be around other people.
Okay.
That's really the biggest deal. And we talk all about you don't know what you're taking, you don't know how potent it is, you don't know how it's going to affect you. So, when in doubt, use less and go slow if you're going to use. And that's universal. That's not just opiates, that's Molly to whatever. So, and be with other people. There's sort of like basic prevention things that are really important for people to keep in mind.
How much naloxone do they actually prescribe in that toolkit? Because I heard that read that the half-life of naloxone is a lot shorter than a lot of the heroin products, or I guess a lot of the opiates. So people can actually relapse and re-overdose even though they receive naloxone. So they receive a lot of naloxone in the kits, or not to get to the hospital.
Oh, that's what you meant by mouth, sorry.
Yeah.
So when we prescribe, or when we dispense for our study, we're giving out 2 doses of intranasal naloxone with the idea, vast majority of people respond to a single dose. Occasionally you need more naloxone, maybe if they're on a lot of dope, or they're on fentanyl, or they're on buprenorphine, something like that. So we always give 2 kits as a backup, and definitely people need to be watched for that 90 minutes. And if you're on methadone, that person really could relapse. Heroin actually has a fairly short half-life. Certainly, fentanyl has a very, very short half-life. The challenge is also the really rapid onset, and it's super potent. So there's different issues with different opiates, and that's why I try not to, depending on who I'm doing training with, I try not to get into the nuances. Like when in doubt, call 911. The challenge is oftentimes if a person's using illegal drugs, they're not going to call 911. So you really need to give them adequate information. And there has been a case in the last couple of years here where a couple guys are hanging out, using heroin, someone had an overdose, gave them naloxone, dude woke up, they went back to watching the movie, dude died. Right? So that happens. It can happen. People need to talk about that. They need to not think, oh, that means my program's not effective, I shouldn't do that. It's like, no, but you got to do really good education with folks so they understand how serious this is. It's obviously a medical emergency to have an overdose. It's not a minor role. Yeah?
What's the cost of naloxone? Are we looking at something that's fairly expensive to distribute to a lot of people?
Naloxone's about $20 a dose for intranasal. And intramuscular, it's all over the place. It's $5 to $10 for a 1 ml bottle. It's almost about the same for a 10 ml vial. Don't really love the 10 ml vial. I don't really want to be giving a multi-use vial to injection drug user. It's not what I would do unless they want to use it and throw it away. So it's, like to say from a medical perspective, that's Band-Aid, that's nothing. And from a public health perspective, it's potentially cost prohibitive. A colleague of mine, actually Sean Sullivan here in the School of Pharmacy, along with Philip Coffin, who's an infectious disease doc, did some cost modeling stuff, and I'm sure I have it up there, but I think it's like $400 per quality adjusted life year. It's ridiculously cost effective, as you might imagine, so to give out